When a person's low back complaints or lower extremity complaints are due to a mechanical joint disorder in the low back, we are looking for the exercise, or possibly two, that when done repeatedly fixes the problem. I would name this diagnosis a mechanical joint derangement, and with that term being used, that implies that we can reverse it with simple movements. Now, there are dozens of different exercises or movements that I use. They need to be performed repeatedly throughout the day to reverse this disorder, and we have to figure out for the individual patient which direction it is, which load it is, the dosage, the amount of force, the frequency, etc. A lot of people respond to extension, either in standing or in prone lying, but of course that's not everyone. There are definitely patients that get worse with extension. So we have flexion, we have side gliding, we have rotation and flexion, and we have extension in a side glide. We call it extension with hips off center. We can also call it extension, with the hips to the left or hip to the right. But the point is actually that it's a combination of prone lumbar extension and side glide of the lumbar spine to either the left or the right. In nearly all cases, if this is the fruitful motion, we are moving the hips away from the asymmetrical or unilateral complaints. For example, just right knee pain or thigh pain that's more dominant on the left versus the right, or back pain that's maybe skewed a little bit more to one side versus the other. We don't know if a movement is fruitful, of course, until we actually investigate it by doing it repeatedly, and me as a clinician looking for the exact angle, exact force, exact dosage, etc. So hips off center, extension with hips off center, is featured in the book because it's one of the ones that we use on a semi-regular basis. It's not as common, of course, as pure extension. I have this idea that I'm trying to suss out. I'm trying to gather patterns, of course, with patients over the years. I think the pattern is that if the person suffered trauma to the lumbar spine, a fall, through athletics or just slipping on ice, or a car accident, etc., I think those people tend to represent more patients who need off-center movements for their lumbar spine versus the person who never had any trauma, major trauma, but is suffering from a lifestyle factor of an imbalance of flexion and extension. I don't know if this is going to pan out, but when I ask patients in the verbal history about their musculoskeletal complaints, I'm often asking, if they haven't brought it up, was there any significant trauma? Because obviously a trauma to the low back can really move the joints in a variety of ways. Trauma does not occur just in the sagittal plane. If you land on your right hip when you slip outside on ice, that direction of force through the lumbar spine is asymmetrical, of course. So lumbar spine prone extension with hips off center is basically going into full extension with the hips to one side. So I'll demonstrate what that looks like, but I also want to point out a few things. People will find it's awkward, and I tell people it should feel awkward but not like awful. If the problem is in the posterior lateral compartment, that's the part of the lumbar spine joints that this targets. So there's definitely theories in terms of the disc model. I subscribe to that disc model presentation or theory. I think it applies to most people for whom these movements help fix their problem. But we're attacking the posterior lateral quadrant. So some people will feel that it's very awkward, and that's normal, because going in the smooth sagittal plane feels a lot more fluid and normal, but when we take the hips to the side, that movement is severely altered. People tend to, over a few repetitions, their hips tend to shift back to the center. So if that's occurring, I have people just reposition and go into the movement again. But I'm not usually getting to hips off center, just like with other non-sagittal repeated movement tests, unless there's some plateau or worsening of the presentation with sagittal plane maneuvers. So it would be very rare that I would look at this on day one, especially if the person was not presenting with a lateral deformity of the spine. Sometimes, possibly, if there's an immediate worsening with extension, But when you're only doing 20, 30, 40 repetitions at a time, you're typically not making someone worse that quickly. And so that's why it bears repeating at home over a few days. But keep in mind that it feels awkward. People are going to usually shift back to neutral. We got to reposition. The positioning of it is typically go on your elbows and glide your hips to the side. I don't want the person rotating or really lifting far off the ground, because we want that motion to stay in the frontal plane. We want to move the hips. How far we move the hips depends on the patient. We typically don't want to go to full side glide, because when you go all the way to end range side gliding of the lumbar spine, you're not going to achieve much extension. So I'm typically going a little bit of the way, a medium amount of the way. But again, the nuance of all this repeated movement testing and algorithm is finding the specific parameters that work for that specific patient. And when we think about that kind of idea of trauma, that makes more sense for people, right? You were hit in a very specific way when you fell at gymnastics practice, or you were hit in a very specific way when you had a bike accident. And that nuance of exactly how the joint was disturbed, if this becomes a mechanical joint derangement as a result of that trauma, that specific direction would be necessarily resolved with a specific direction. So for some people that means moving into more side glide with extension, and for some people that means less. The proof is in the pudding, so to speak. The proof is in, does the repeated movement testing show that doing this more and more with all those parameters individualized to be therapeutic, does it show that we are reversing signs and symptoms in the expected amount of time? So let me show you how it looks. It's a little bit hard, of course, with this camera angle. I don't have a professional camera crew, but if you're going prone, you're going on elbows, and then you're just shifting the hips to the side and going up like this and dropping. Going up and dropping. So the patient is not very far off center. We can also sustain it on elbows. We can also add force, of course, with external hands from the clinician or someone at home, or with a belt. But as a demonstration, that's just some things to keep in mind. It is a movement that we use for a decent amount of patients, again, not only with lumbar complaints, but also lower extremity complaints, because we find so much mechanical problems in the low back creating mechanical problems in the lower extremities, also referred symptoms, also radicular nerve symptoms as well. So if you're interested in more descriptions of the application of this, the Treat Your Own Back book does describe it. Keep in mind though, it's something that we do use on a regular basis.